All right, let's jump right into this explainer. Look, if you're gearing up for your oral medicine or pathology exams, you already know the drill. Pigmented lesions can be a seriously overwhelming topic. I mean, there's just so much to memorize, and honestly, the conditions can all start to blur together. But today, we're going to fix that. This explainer is built to be your absolute ultimate cheat sheet. We're going to take this massive mountain of clinical data and transform it into a highly structured, super easy to recall master blueprint. To do that, we're building a master mental map across 6 high-yield sections: classifying lesions, brown focal melanotic, brown diffuse melanotic, red and blue vascular, black and gray lesions, and heavy metal toxicosis. By the time we wrap up, you'll be able to navigate straight from a visual clinical presentation right down to the specific microscopic and systemic etiologies. Section 1, classifying lesions, the master blueprint. Let's lay down the absolute foundation because, let's face it, you can't diagnose what you haven't organized in your head first.
Now, what's really brilliant about this slide is how beautifully it simplifies all that chaos. This is your master classification cheat sheet. Notice how it categorizes everything first by clinical color, so brown, red, and blue, and black. And then from there, it subdivides based on the spread. Like, is it focal, meaning just a single localized spot, or is it diffuse and multifocal? When you're sitting there looking at an exam question, your brain should literally snap right to this grid, right? Is the lesion brown and focal? Bam, it's likely a nevus or a macule. Black and diffuse, you gotta start thinking about heavy metals or black hairy tongue. Pin this chart in your memory, seriously. It is the absolute framework for the whole shebang.
Moving on to Section 2, brown focal melanotic lesions, spotting the details. This is a super popular area where examiners just love to test your differential diagnosis chops. And here's a classic exam curveball, contrasting the nevus with a melanotic macule. Okay, so an oral melanocytic nevus is just a benign growth of melanocytes, right? But the high-yield exam detail here? It's the preferred location, which is the hard palate. It usually shows up as a small, solitary, static nodule or macule. Contrast that with a melanotic macule. This one's often trauma-related, it favors the lower lip and gingiva, and actually shows up more frequently in females. Oh, and here is a crucial detail for your exams. Unlike a regular skin freckle, a melanotic macule absolutely does not get darker with continued sun exposure. If a test question mentions a lip lesion that totally ignores the sun, well, you know exactly what it is. Now, we also have to talk about malignant melanoma in this focal brown category. While it is the least common, it's definitely the most deadly. The detail that will reliably score you a point on test day is remembering the most common oral sites. The palate represents the single most common site, closely followed by the maxillary gingiva. Clinically, you evaluate it using those classic ABCDE criteria: asymmetry, irregular borders, color variegation, diameter greater than 6 millimeters, and evolution. And microscopically, the buzzwords you are hunting for are clusters of pleomorphic melanocytes showing nuclear atypia and hyperchromatism within the basal cell region. Okay, before we leave brown lesions entirely, let's do a quick knowledge check. Can you identify the systemic syndrome that presents with diffuse perianeural macules, features GI issues like intestinal polyps, and has macules whose intensity is totally unbothered by sun exposure? Section 3, brown diffuse melanotic lesions, systemic clues. If you guessed Peutz-Jeghers syndrome for that last question, you are absolutely spot on. Now, while focal lesions are often just localized issues, diffuse brown lesions frequently act like a window into broader systemic and endocrine conditions. And examiners love to see if you can differentiate these systemic syndromes. Whatever you do, don't confuse Peutz-Jeghers with Addison's disease. Like we just said, Peutz-Jeghers is an autosomal dominant disease marked by intestinal polyposis and multiple circumoral pigmented macules that ignore the sun. Addison's disease, on the flip side, is caused by hypoadrenocorticism, adrenal insufficiency. Because cortisol is low, the body goes into overdrive pumping out excess ACTH, which concurrently raises melanocyte-stimulating hormone. The result? A generalized bronzing of the skin and patchy melanosis of the oral mucosa, usually tagging along with clinical weakness and fatigue. Always look for those high ACTH lab values to confirm Addison's on an exam. But hey, not all diffuse brown lesions are genetic or endocrine. Some are exogenous. And this is a brilliant example of how location is a massive diagnostic clue. Take smoker's melanosis, for example. It specifically hits the anterior facial, maxillary, and mandibular gingiva, forming these irregular, flat, map-like pigmented areas. Conversely, drug-induced pigmentation, which is often caused by antimalarials or that acne medication minocycline, that frequently localizes to the hard palate. So remember, same color, different spread, totally different etiology. Let's shift gears to section 4, red and blue vascular lesions, testing the flow. We're moving off melanin and onto hemoglobin and imosiderin. This is a category where literally a single, simple clinical test can completely make or break your diagnosis. And that crucial test is diascopy. This is an absolute must-know high-yield definition for both your clinical practice and your exams. Here's how it works. If you have a red or blue lesion, you just place a clear microscope glass slide right over it and apply pressure. If the lesion blanches, meaning the blood is physically pushed out of the vessels and the color temporarily vanishes, you are looking at a vascular lesion where blood is still contained within the vessels, like a hemangioma. Let's compare two of these key vascular conditions. A hemangioma is characterized by endothelial cell hyperplasia. It typically appears pretty rapidly after birth, and crucially, it blanches under that diascopy pressure we just talked about. Now compare that to hereditary hemorrhagic telangiectasia, or HHT. This one's an autosomal dominant disorder, but the pathophysiology is wildly different. It's actually caused by a lack of elastin, which decreases the structural support of the vessel walls. The major clinical buzzwords you want to look out for with HHT are frequent nosebleeds, also known as epistaxis, and mucocutaneous lesions that bleed profusely with just minor, everyday trauma. All right, let's move to our next color category on the master blueprint with a really practical question. Say you're examining a patient and you spot a focal gray-black macule. How do you know for sure if it's an amalgam tattoo or a graphite tattoo? Because visually, they look incredibly similar. Section 5, black and gray lesions, exogenous marks. To answer that question, we have to dig into these black and gray lesions. Whether focal or diffuse, this specific color category is almost entirely driven by exogenous factors, which basically just means substances introduced from outside the body. So the differentiator between those two tattoos really just comes down to history and anatomical location. Amalgam tattoos are iatrogenic. You'll find them sitting near dental restorations, crowned teeth, or old extraction sites where amalgam particles essentially got deposited into the submucosa. Graphite tattoos, however, are a super unusual source of exogenous pigmentation, and they're almost always found directly on the palate. They are the result of a traumatic implantation of graphite from a childhood pencil accident. And honestly, because it happens in childhood, the patient often won't even remember the injury. I mean, who hasn't accidentally been stabbed by a pencil in the second grade, right? Now, for diffuse black lesions, black hairy tongue is going to be your go-to diagnosis. This typically occurs on the middle and posterior third of the dorsal tongue. What's actually happening on a microscopic level? The filiform papilla become really elongated and hyperplastic. These hair-like extensions then basically become a cozy home for chromogenic bacteria. And what triggers all this? It's highly associated with local environmental changes. Think chronic antibiotic use, heavy reliance on antiseptic mouthwashes, poor oral hygiene, or heavy smoking. Section 6, heavy metal toxicosis, the clinical curveball. Finally, let's tackle the curveball that examiners just absolutely love to throw at you to test your deep textbook knowledge. This falls under diffuse black and gray lesions and brings some really fascinating systemic symptoms along for the ride. Let's add another tool to your diagnostic toolkit. If you see a dark line along the gingival margin, you need to bust out the paper corner test. It's super simple. You insert the corner of a small piece of white paper right into the gingival crevice. If the dark color disappears from view, you're likely just looking at dark subgingival calculus shining through the tissue. But if that gray-black color is accentuated against the white paper, you are looking at a true metallic line. That is an insoluble precipitate of metal sulfide caused by heavy metal toxicosis. Seriously, take a mental snapshot of this chart right now. This is pure exam gold. Heavy metals get ingested and then extravasate into areas of chronic inflammation in the mouth. You have got to be able to match the metal to its specific manifestation. Lead exposure, which often comes from old water pipes, is famously tied to peripheral neuritis and hemolytic anemia. Silver causes this generalized, almost cyanotic-looking skin condition known as Argyria, and bismuth, which also causes that metallic line, is actually most often tied to therapeutic use rather than environmental poisoning. And here is your specific, ultra-high-yield buzzword to memorize for the mercury category, acrodynia. If an exam question describes a child with painful, pink discoloration in their hands and feet, combined with oral issues like excessive salivation or the premature exfoliation of deciduous teeth, you are undoubtedly looking at chronic mercury exposure. Hit that answer and move on.
To wrap up this explainer today, I want to leave you with a real-world application. Imagine this scenario. A 45-year-old female presents with a static, half-centimeter brown macule on her lower lip. Pull up your new mental blueprint. It's brown, it's focal, it's on the lower lip in a female. Your top differential should immediately be a melomotic macule, likely related to past trauma. See, this is exactly how you use structured knowledge to conquer complex diagnostics. Review this structure, master the blueprint, and you are going to absolutely crush this topic on your exams. But it really makes you wonder, doesn't it? If a simple spot on the lip can reveal so much about a patient's history, what other systemic secrets might the oral mucosa be hiding in plain sight?